Hi, good evening, everyone. I'm taking this second part of this imaging role of imaging in infections, rather. So last Wednesday we discussed about the patterns of disease. Um, now I'm moving on to this imaging of community-acquired pneumonia. So by definition, the community-acquired pneumonias are defined. Is defined as infectious pneumonia that is acquired in the social community. That's very simple. We have other part of it called nosocomial infection that is acquired in the hospital. I'm going to talk only about this community-acquired pneumonia. It is called CAP. The pathogens of CAP are usually any ordinary bacteria, and also the mycobacteria can cause this community-acquired pneumonia. Viruses and fungi also are also causative organisms of this community-acquired pneumonia. So these manifest as the pneumonia manifests in various forms, and the imaging findings are often non-specific. By looking at a radiograph or a CT, it's hard to guess an causative organisms in more often than not. So again, the characteristic, if you see, anytime you see a characteristic imaging findings consistently, and a specific pathogen is isolated, then we can say that could be the disease process could be because of that specific pneumonia. But this doesn't happen most of the time. It's very hard to differentiate types of pneumonias on the imaging. But nevertheless, we can certainly say there is some infectious process going on, and then we can help the physicians in follow up. Moving on to the next. So here are some of the organisms which cause community-acquired pneumonia, which have the pattern, like Streptococcus pneumoniae causes alveolar or lobar pneumonia, Mycoplasma pneumonia, predominantly bronchopneumonia, wall thickening of central bronchi, Chlamydophila pneumonia, it causes infectious bronchiolitis with bronchial dilatation. I'll show you the examples as we advance further into the talk. So Legionella pneumonia, again, there are patterns which are relatively specific to these organisms, which can be identified in some of the cases, not in all. So now, what is the role of imaging? That's the main concern for us today. It is very obvious if patient comes with a fever, cough, sputum, and then imaging findings you see on a radiograph, a pneumonitic patch or any ill-defined opacity, we can confidently say it's an infectious pneumonia. Right? So it's not that difficult. Many times they do this imaging just to confirm, and then rather for follow-up, in the sense that the patient is relieved of symptoms. It can be used as a follow-up imaging. The imaging like a chest X-ray can be used as a more than if the physician is sure that patient has a pneumonia, he can avoid doing a chest radiograph in the first place. If he wants to do it, that will be for confirmation and then for follow-up. So hence the imaging examinations play a complementary role for evaluation of treatment effects of antibiotics, as I said. May also be used. This CT and probably less chest radiograph can be used to differentiate the infectious from non-infectious causes of the pneumonia. And many times the imaging can also reveal the underlying diseases that result in pneumonia, like say a mass, endobronchial mass, or a perihilar mass that causes consolidation can be identified in this imaging. So when do we do CT? We don't do CT for all community-acquired pneumonias. So when the pneumonia is very severe or complex or involving both lungs, so that's the time you go ahead and do what is the cause for pneumonia, or pneumonia in immunocompromised patient. If the patient's got HIV, or a patient is on chemotherapy, or some sort of immunosuppression is there. So in that patients, you can probably do a CT in first instance. And then pneumonia is not amenable to antibiotics. It's not being treated by antibiotics. Then that's when you should start to think something else, especially in children. They've swallowed some foreign body, and as a result, the antibiotics you give may not really help them relieve of the symptoms. So that's where the role of CT is, and then patients with clinical suspicion of pneumonia but normal or questionable chest radiographic findings. Okay, to prove that there is a pneumonia, you can go ahead and do CT, but often this is not required. And then pneumonia with suspicion of underlying diseases. So these are the some of the indications where we do CT in case of community-acquired pneumonias. So now we have patterns of imaging findings in this community-acquired pneumonia. They are broadly divided into three. One is a consolidation like alveolar or lobar pneumonia. Next is the peribronchial nodules, are also called as bronchopneumonia. The third one is a ground glass opacity, and a fourth uncommon pattern is called random nodules. It's mainly due to the heterogeneous spread of infection. So here is an example of consolidation, alveolar or lobar predominant pattern. You can see on the right side, you can see segmental consolidation here, that is very well shown on the CT with air bronchograms. So you shouldn't have any difficulty in identifying this. So this is a tuberculous pneumonia patient where we see we do see this consolidation process. But how is it different from the other bacterial pneumonias is that you can see the bronchi demonstrates there's some sort of traction bronchiectatic changes with dilatation of the bronchi, and we are seeing some cavities. Okay, this will favor, and apart from this, if you also have central lobular nodules, which suggest that endobronchial spread of infection. So you can think of a tuberculous pneumonia, especially in post-primary tuberculosis. So now the peribronchial nodules predominant pattern is characterized by predominance of peribronchial nodules, including central lobular nodules with or without peribronchial consolidation. So bronchial wall thickening is often seen in these patients, and bronchopneumonia is sometimes indistinguishable from the alveolar pneumonia. So this is it's a fully blown bronchopneumonia. It may be difficult to differentiate it from the alveolar pneumonia. When the central lobular nodules predominate, we can also call this as infectious bronchiolitis. So here is an example. It's nothing but you can see a tree in bud appearance, that classical appearance I've already discussed in the last class. You see that V, Y, inverted Y, multiple of them, which are slightly branching. So this is a magnified view of the same. And then initially, as I said in the last class, also it was thought to be specific of tuberculous infection, but it is not so. Pneumophilas, influenzae, Mycoplasma pneumonia, chlamydophila pneumonia, all this can, and even some of the virus can cause this appearance. So don't fall for that. The very fact that whenever you see this endobronchial or rather central lobular nodules, or you have to think there is a definite infection, but you don't know what infection it is. Right. So now the next pattern is the ground glass opacity predominant pattern. So infectious pneumonia sometimes appear as ground glass opacities. Pathologically, this ground glass opacity is nothing but the alveoli are filled with inflammatory cells or exudates, and the pulmonary edema second to infection, leaving air in the alveoli or interstitial infiltrates of inflammatory cells. That is how we see these ground glass opacities. And then the pattern of infectious pneumonia is sometimes referred to as interstitial pneumonia. Right? This ground glass predominant is mostly seen with the viruses, but it is not specific again. As I said, this is an example here. You can see on the chest radiograph. We see those patchy ground glass opacities. We might think it is a pneumonia, regular pneumonia. But we don't see any air bronchograms. So this is a CT of the same patient demonstrating those patchy ground glass opacities. So you need to correlate with the history and then come to a conclusion. So these findings are pretty non-specific. You cannot say what is causing it. You can only say there is certain disease process. If this is not pulmonary edema, so most probably this is an infection or some sort of inflammatory process happening. So the next pattern is the random nodules predominant. This is the fourth one. It's a fourth one, and it's caused by the hematogenous spread of disease, or most commonly seen with the granulomatous infections. Even some viral pneumonias can give rise to this appearance. So varicella zoster as a specific pattern. I'll show you the images. So heterogeneous dissemination of pathogens such as miliary, tuberculosis, or septic emboli, they will also fall into this category. Even septic emboli can be categorized into this random nodules predominant category. So here are some of the examples. On the top left image, you can see that's the infection caused by varicella zoster. You can see these nodules, very indeterminate or non-specific nodules. You don't know what it is. But if you put the clinical scenario into the clinical scenario and correlate with the lab findings, probably we can tell that it's probably related to the varicella pneumonia. In the left bottom image shows that these septic emboli are classically located, randomly distributed, peripherally located. Majority of them show this cavitation. So that's what you have to remember. If you ever see cavitating nodules at the periphery, randomly distributed, they are not round like metastatic cannonball. It's not like cannonball type of metastatic lesions. They're usually little ill-defined with cavitation. That's when you can think of septic emboli. And invariably, these patients will have some sort of focus like infective endocarditis or some other infective focus which is coming to the lung. So on the right side, you can see on the top image chest radiograph demonstrating fine miliary pattern. The same thing demonstrated on CT. This is multiple miliary nodules seen everywhere of slightly varying sizes. Okay, so imaging findings. I mean, I've already discussed this Streptococcus pneumonia. The presentation, how do they present presentation? The Streptococcus pneumonia usually in most common CAP, as you all know, and it accounts for 40% of CAPs. This is usually either alveolar or lobar pneumonia on the chest radiograph, and it can easily be seen on CT. So lower lobe is potentially involved, but multi-lobe involvement is also common. So bilateral lung disease is seen in about half of the cases. So there's so many variants here. So hence you cannot bang on and say it is Streptococcus pneumonia. Probably we have to do a sputum culture and appropriate antibiotic to be given. Same, I've already shown this lobar pneumonia, the upper lobe. So how does the Mycoplasma pneumonia look like? It usually affects the young people, and it is characterized by dry cough, fever, and general fatigue. And chest radiograph shows radicular nodular opacities or patchy consolidation. Again, on CT, we may see the central lobular nodules and lobular to acinar areas of consolidation, or GGO with bronchial wall thickening consistent with bronchopneumonia. So you basically have to look for this, central lobular nodules. Then usually targets bronchial epithelium. Hence, more often than not, you will see this bronchial thickening. So bronchopneumonia with central bronchial wall thickening in children and young adults are fairly specific findings. As I said, for Mycoplasma pneumonia, here is an example on chest radiograph. It's difficult to make out that it's a Mycoplasma pneumonia, whereas on chest radiograph, usually a single lobe involvement, right? And you can see this. You can have associated ground glass opacities, and then some central lobular nodules. I mean, if the disease is imaged early part of the infection, probably it gives us more clues than as it progresses. As it progresses, so it's not very easy to diagnose. If you are, especially if you are in a tertiary care center, patients come late to you, and then it may be difficult to diagnose these conditions on imaging alone. So hence we need to rely on the sputum examination also. So next one is Legionella pneumonia. Is a fatal pneumonia, and therefore early diagnosis and treatment is very crucial. So chest radiograph findings include unilateral non-segmental, poorly defined air-space consolidation, again non-specific. CT findings consist mainly of consolidation and ground glass opacities. And bilateral lung disease is seen in 2/3 of cases. It has been reported that sharply marginated consolidation, peribronchial consolidation with ground glass opacities. So these are all you can see these are all the ground glass opacities. If you ever see something like very well defined consolidation within the pneumonia, So you can think of a Legionella pneumonia here. So viral pneumonias, again, the numerous viral viruses that cause these pneumonias. It can present in any form, what we have discussed so far. So, but common among them are bronchopneumonia and ground glass predominance are the most common presentations of viral pneumonia. So, random nodule pattern is not it's not very common, but it's often seen in this varicella zoster infection, and right, and then due to the fact that the reason is when you see this randomly distributed nodules, you can infer that it is a hematogenous spread. So this is an example. We can see randomly distributed ground glass opacities in the upper lobe regions, and you can also see this small central lobular nodules. So with this we can say that there is sudden infection, but it's hard to put them. I mean, hard to categorize them. What is causing this? We can only guess that it's most probably a viral type of pneumonia, depending on the presentation, clinical presentation. So fungal infections, how do these present? These fungal infections, fungal pneumonia is not very common in immunocompetent individuals, except for the cryptococcosis, which can occur in nearly immunocompetent patients. The most common seen with immunosuppressant patients like HIV, AIDS, or patients on chemotherapy, or patients receiving bone marrow therapy, getting bone marrow transplant and things like these. People are usually the ones who are targets for these fungal infections. Hence, utmost care is needed. So it can again present as alveolar pneumonia or bronchopneumonia, or sometimes with nodular lesions with or without cavities. So pneumocystis carinii pneumonia, which was reclassified as fungus, now it is called pneumocystis xerovaccae from carinii. It is now called xerovaccae. It usually presents as bilateral ground glass opacities with or without parahilar distribution, unless patient is treated, may progress into consolidation. It is an example. It's very difficult unless you have a background, have a history of patient has got HIV. That's when you can probably think of pneumocystis xerovaccae infection. This is how the pneumocystis infection would look like. So now a small quiz. So what is this now? I have a few images which looks like a pneumonia. Do you think is a pneumonia? Any responses? I don't know how to say it, but anyway, this one is this is actually a non-infectious pneumonia. This is cryptogenic organizing pneumonia. You can see there's a consolidation, but the only thing is it's getting kind of organized with and it is kind of outlined by these fissures. It looks a little more organized than the regular pneumonia, which is more fluffier. And you can see in this bottom down image these pneumonitis patches, which have a characteristic pattern of reverse halo sign. Here, the central ground glass is surrounded by consolidation. That's a reverse halo, which is commonly seen in this cryptogenic organizing pneumonia. So you need to be aware of these non-infectious pneumonias as well. So how does this present? So what are the clues for us in this patients? Especially these patients come to us with chronic dry cough and dyspnea for a couple of months. Usually, the infectious pneumonias will not progress that long. So you have to take into consideration again the clinical history here, which suggests that patient has been having for a few months of cough and dyspnea, and then these people don't respond to the antibiotics. They would have received at least 4 or 5 courses of antibiotics. In spite of that, they will not respond. So I've already described this reverse halo sign, right? So although this was considered again specific for COP, it has been shown that it is seen with many other disease conditions. Hence, it is not specific. However, you can note it has not been reported that reverse halo was seen in the CAP so far. It is considered useful to differentiate hence it is considered useful to differentiate COP from CAP. Right? If you ever see this, so you have to think in lines of cryptogenic organized pneumonia. It's reverse halo sign. I'm talking about reverse halo sign. So which can be seen, as I said, in all these pneumonias can show this reverse halo sign, like fungal infections, pneumocystis infections, etc. So to sum up, there is no imaging finding of these CAPs. There is no finding that is 100% specific for infectious pneumonia. So you have to look at the consolidation and ground glass opacities are actually non-specific. It can be seen in any pneumonia, bacterial, viral, fungal. So hence you cannot go by that. Peribronchial nodules, especially green bud appearance, are fairly specific for infection. If you ever see this green bud appearance, you can be very sure that there is, you're looking at infection. You can rule out non-infectious causes when you see this green bud appearance. When viewed with CT, consolidation, ground glass opacity, and peribronchial nodules are coexistent in most cases of infectious pneumonia. Right? So therefore, peribronchial nodules can often be a diagnostic clue for infectious pneumonia. That's all we can say. So moving on to the next topic of tuberculosis. Tuberculosis. We have, you all know, it's a primary pulmonary and post-primary tuberculosis. So how do we? I'll go through. I'll show some of these slides, and at the end I'll show a tabular form, a summary of these two tuberculosis forms. So the initial in this primary tuberculosis is mainly seen in the young children, and it can be the initial focus of infection can be located anywhere within the lung. It's not specific. It can be too small. Sometimes it is detectable, not detectable. Sometimes patchy areas of consolidation may be seen, or even lobar consolidation. It can present with any of these, as I just described, and then as you see, the radiographic evidence of parenchymal infection is seen in 70% of children and 90% of adults. So pretty much, it's a good rate. Radiograph, we can diagnose that we are dealing with a pneumonia. We have to decide whether it's tuberculosis or not. So again, in primary tuberculosis, the cavitation is very uncommon and seen in only in 10 to 30% of cases. So this is one of the differentiating features of primary and post-primary. Then a word about gone lesion. In most cases, infectious lesion becomes localized because of the host immune response and cascading granulomas form. It's called tuberculoma, which eventually calcifies. So this is what we see as these, prior multiple pulmonary calcified nodules. If you see, it's probably related to this prior infection, Gons lesion. So striking finding in this primary tuberculosis, especially in children, is that ipsilateral hilar and contiguous mediastinal and lymphadenopathy. This is one feature that is commonly seen in primary tuberculosis. Remember, lymphadenopathy is commonly seen. And then this is seen in over 90% of cases in childhood primary TB, but in adults it is not very common. It's only seen in 10 to 30%. Typically, have low density centers. These granulomas have low density centers with rim enhancement. Okay, pleural effusions. It's not just an associated findings. Could be seen in 30 to 40% in adult cases, and then 5 to 10 in pediatric cases. As a host, as I said, immune response improves, both pulmonary and nodal disease resolves. So calcification of nodes is seen in 35% of cases. When a calcified node and a gone lesion are present, the combination is known as rank-A complex. Just for a theoretical part, this is how it can present. The primary tuberculosis can present as, this looks like a lobar pneumonia in the right upper lobe. It can present in any form. Right, as I said, it could be a small focus hiding somewhere, or a lobar pneumonia, or a subsegmental consolidation, etc. So post-primary, it's also called reactivation tuberculosis, and most commonly seen in the adults. And this happens when the immune status of a patient deteriorates, especially in patients with, diabetes mellitus and things like that, or old age. This can pop up. These post-primary tuberculosis are most commonly seen in those patients. And then, as I said, unlike the primary tuberculosis, it's most commonly seen in the posterior segments of upper lobes and superior segments of the lower lobes. So the post-primary, these are the common sites. And typical appearance of post-primary is a patchy consolidation of poorly defined linear or nodular opacities. I'll show you an example. This is how it looks like. The secondary tuberculosis or post-primary. You can see this patchy consolidation here and there with cavitating nodules on CD. You can characteristically see these cavitating nodules. If you ever see these thick nodules, then alveolar opacities, and then you can see this the three bud appearance as well. You see all these findings together, you can confidently say this is a post-primary tuberculosis. Cavitation, as I said, is more common in secondary tuberculosis than in primary. And if you ever see a air fluid level, it's suggestive of a lung abscess, and that's probably an open case. Patient may be giving out a lot of sputum, and then is basically a very active case of tuberculosis. Then endobronchial spread is a relatively common finding, as I said, resulting in that tree bud appearance. So hilar nodal enlargement is not very common, seen in only 1/3 of patients. The lobar consolidation, tuberculoma formation, and miliary TB are also recognized patterns of post-primary TB, but are less common, right? So tuberculoma is more with the primary, and miliary TB is again, it may or may not be seen. If it is miliary TB, then most probably we're dealing with a hematogenous spread, right? And this is an example of so coming on to the next form is miliary pulmonary tuberculosis, and it's very uncommon, but it carries a very poor prognosis. Again, it's more common in the it's because of the, as I said, more common in immunocompromised patients. Like even HIV patients are more prone for this miliary tuberculosis. Hematogenous dissemination is the cause for this. It is seen in both primary and post-primary. It can be seen in both. Although implants are seen throughout the body, but lungs are usually the easiest location to image. The second commonest is the kidney. Miliary deposits is already described, 103 millimeter nodules, which are uniform in size and uniformly distributed. An example of miliary tuberculosis. So a word on in AIDS patients, how is it present? How does it present in AIDS patients? Patients with AIDS demonstrate altered patterns of infection depending on the CD4 cell count. When the CD4 cell count drops to 350 cells per millimeter cube, pulmonary manifestations appear similar to run-of-mill post-primary. That means it looks very extensive post-primary tuberculosis. It appears like extensive post-primary. When CD4 count drop below 200, then the pattern is more likely to resemble miliary or even primary tuberculosis. Nodal enlargement is again common at this stage. And just a word on multi-drug resistant tuberculosis. I don't have a slide of that, but however, the imaging findings do not change. It's only the organisms that are resistant to the certain antibiotics, but the imaging findings remain same. So here is a summation of findings in primary and post-primary. Consolidation in primary is patchy or lobar, whereas post-primary is patchy, nothing much to differentiate. Location anywhere, whereas in post-primary it is posterior segment of upper lobe and superior segments of the lower lobes. Cavitation uncommon in primary, common in post-primary. Granuloma tuberculoma formation is more common in the primary, less common in post-primary. Lymphadenopathy again is more common in the primary and seen in 90% of children and less common in post-primary. Pleural effusions non-specific again, and then tree bud appearance. It can be seen with both of them. It is not specific to anything, but more commonly seen in the post-primary. Thank you.